Hello, and welcome to Medical Myth Busting. We are going to take a look at all of the myths that exist in our community around medicine, and we're going to bust those myths with some truth. We know that we can have better health outcomes, but our community has to be informed. And in order to be informed, we need to get the right information. That's why we partnered with Wayne State University. We have faith leaders and people in the faith community, and we're going to do everything that we possibly can to make sure that we have the best health care information, that we have the best health care outcomes, and that no longer will our people perish from a lack of knowledge. I'm attorney Bertram Marks. I'm sitting here with the president of Wayne State University, Dr. Roy Wilson, and also with Dr. Haley Thompson. Dr. Wilson, this effort by the faith community, the community at large, to improve healthcare outcomes, when this was mentioned to you in the early stages, you weren't just interested, you seemed very excited about it. What was it about this kind of partnership that got you so excited?
Well, first of all, Bertram, thanks so much for bringing it to my attention. I have so much faith and so much confidence in the faith-based community to be able to get the word out to its communities. I feel very strongly that in order for our communities, and particularly minorities and African Americans in particular, to really achieve the best possible health, not only do they need the right information, which you've mentioned, but they also need to be fully participatory in terms of the research studies to be able to participate in the new treatments and the new drugs coming. And I knew that that was your intent, and I knew that we have really great people on our staff, Haley Thompson being one of our superstars, and I thought that this was going to be a really good match.
We're very excited that Wayne State University has adopted this program. Medical mistrust is an issue in our community, and it's not unwarranted, as you and I have discussed. But one of the first things you did to foster this partnership is connect us with Dr. Haley Thompson. And Dr. Thompson has a unique sensitivity to communities of color, and her ability to relate really made this faith community research network that we created, it really made it blossom in ways that I don't think any of us could have expected. Dr. Thompson, thanks for joining us today, and I just want you to spend a little time talking about the controls that are in place when it comes to medical research and trials and participating. There are some ethical controls that are in place now. Is that correct?
Absolutely. Thank you so much for having me here today. I think it is really critical that our communities understand more about the research process. One of the goals of our Faith Community Research Network, that is a partnership with you, Bertram, and the Faith-Based Genetic Research Institute, Wayne State University, and Carmanos Cancer Institute, is to build partnership with diverse communities, and particularly the faith community, when it comes to research. We have something called an institutional review board that reviews all the research that comes through our university. Every university and every institution, every hospital has an institutional review board that ensures that we are providing more benefit versus harm when it comes to investigating disease, investigating chronic conditions, and thinking about how do we address health disparities.
Through great people like you, Dr. Thompson, and you, Dr. Wilson, we know that faith without works is dead. We now have a faith commitment and some work behind it, and it is going to change healthcare outcomes for our community. This is culturally targeted research. It's designed by us and for us, and it's going to improve our life expectancy. It's going to improve our quality of life, and these are the kinds of efforts that really make a difference. So once again, thank you, Dr. Wilson. Thank you, Haley Thompson. This is Medical Myth Busters, and we have a great lineup of physicians and researchers and information, faith leaders, and we know that you're going to enjoy what you see. Thanks for joining us.
Welcome to the Faith Community Research Network Town Hall Medical Mythbusters on hypertension. Before we do anything, we want to allow you to know that prayer is important. So we're going to ask Dr. Eddie Connor to give us a word of prayer, and we'll introduce you more about the network and the town hall on hypertension. Dr. Connor.
Good and gracious God, we thank you for this opportunity today. Your word says that you would that we would prosper and be in good health, even as our soul prospers. So give us revelation for every situation. We thank you for giving us insight. We thank you for the panelists. We thank you for the contributors who are here to shed light, but also to give us information to change the course of our health, our well-being, and our life. In Jesus' name, amen.
Amen.
Amen. Thank you, Dr. Connor, for that awesome prayer. Again, welcome to the Faith Community Research Network, Medical Mythbusters on Hypertension. The Faith Community Research Network is a collaboration between Wayne State University, the Faith-Based Genetic Research Institute, and Carmano's Cancer Institute. My name is Rochelle Chapman. I am one of the co-directors of the Faith Community Research Network. I'm also the Community Engagement Coordinator here in iBio at the Center for Urban Responses to Environmental Stressors. And I have just maybe a few short titles of Dr. Levy. He has about 20. My title also is a senior pastor with my husband of New Beginnings Bible Church. I'll ask Dr. Connor to introduce himself, Dr. Opara, and then Dr. Levy.
Yes, Dr. Eddie Connor, best-selling author, empowerment speaker, and mentor.
Yes, thank you. I'm Dr. Ijeoma Nodim Opara, and I am a double board certified internal medicine and pediatric physician, primary care. I'm also a scholar and activist doing a lot of work in health justice. I lead a lot of efforts in the area of health equity justice here in Wayne State, locally in Detroit, but also throughout the nation and globally as well. I'm really excited to be here on this panel. I work very well with Dr. Levy.
That's my good friend and colleague, Dr. Opara. I'm Philip Levy. I'm a professor of emergency medicine at Wayne State University, where I also serve as assistant vice president for translational science and clinical research innovation. In addition, I'm chief innovation officer for Wayne Health, and I'm the principal investigator for Achieve Greater and LEAP Hypertension, which are two large programmatic grants focused on reducing the impact of high blood pressure on our communities here in Detroit and extending to Cleveland. And we'll talk about these a little bit today.
Thank you, Dr. Opara and Dr. Levy. Dr. Opara and Dr. Levy, can you give us some more about your research and your background so that we can make sure our viewers know a little bit more about that?
Oh, absolutely. I can start.
Please.
Okay. So as Dr. Levy said, as the principal investigator of the project Achieve Greater, which is funded by the NIH, the National Institute of Health, I'm also honored to be a co-investigator in that research, also in collaboration with the American Heart Association. That grant funds a lot of our work dealing with how do we address the issue of hypertension here in the city of Detroit as it relates to Black communities. We know there is a lot of disparities around our health and our life outcomes, and all of it really can be traced to cardiovascular disease, principally hypertension. Now, a lot of work has been done to try to address the issue, but one of the areas that we haven't really invested time, research, and practice in is around addressing the social context, the social determinants that impact majority of our health. That means our housing, education, early childhood experiences, and the list goes on. And so what we are answering one of the questions we're answering in our research efforts is if we're able to take community health workers, folks from the community, give them good training and have them address those social determinants of health, perhaps we can begin to turn the tide of hypertension in our community so that we can live long, healthy, thriving lives. And so this is the work we do amongst other pieces in our research projects, and also the work we do clinically and even through education as in our affiliation with Wayne State University School of Medicine. Phil, would you like to add to that?
Absolutely. So can you tell that I picked the right co-investigator for this project? Someone who's passionate about working with the community and really understands the needs of the community. But maybe to take a little bit of a step back, I'm an emergency physician. I've worked at Detroit Receiving Hospital for more than 20 years, and I've seen the ravages of what hypertension can do to a community if it's not addressed early on. People who come in to the emergency department with strokes, heart attacks, acute heart failure, kidney disease, kidney failure. And they often say, I've never had a medical problem in my whole life. Well, that's not exactly true. You were probably told along the way that your blood pressure is elevated. Perhaps you didn't have the best access to health care, or maybe you didn't have health insurance, or maybe you just didn't have the right providers to work with you to understand the importance of prevention as opposed to treatment. And so my journey to be where we're at today starts in the emergency department with getting a little fed up, not with the people that come in, but with the circumstance that leads to 40-year-old black men on dialysis or 50-year-old black women suffering from life-altering and debilitating strokes. And so what we started to do prior to the pandemic, several years ago, was focus on the emergency department as a point where we can screen people for high blood pressure. Everybody who comes to the ER gets a blood pressure measured. But the blood pressure that we detected today that's elevated is going to be the factor that's a problem. And we are not geared as a health system to be responding to these needs in the emergency department. That's not what ERs were built for. However, because we practice in an urban environment, in Detroit where access to care is pretty poor, and a lot of folks go with untreated hypertension, we started to build out an agenda, if you will, around screening in emergency departments for high blood pressure. We then started taking the information and said, we cannot only, well, say it this way, we didn't only intend to just help the people in the ER, we can take this information and understand what's going on in the communities where these folks live. So we started to say, okay, if we design these programs to screen in the ER, how about the data stepping back? Can we apply that to the communities where people live and then layer on social determinants and get an understanding of what community needs are and where we should focus interventions to try to decrease that risk of developing high blood pressure and related complications? We have to understand what people, need to get to the, to the bottom of their problem, to hit, to help this problem around hypertension. And then we need to be able to supply the resources, not just throwing more money at the equation, but using existing resources in the community and aligning people with existing resources so that we can address these other social determinants and help people's blood pressure.
As Dr. Levy said, it's so important, this sort of nickname of hypertension as the silent killer, because not only is it that a lot of people find out they have high blood pressure or hypertension when they get it checked, like at a health fair or in a doctor's office, but oftentimes people find out they have high blood pressure when they have that stroke, right? Or when they have that heart attack, right? Or when they come in with heart failure. This is the key. Hypertension is preventable. Hypertension-induced stroke is preventable. Hypertension-induced heart attack is preventable. Hypertension-induced deaths are preventable. And so what this conversation is about, how do we begin to be part of that story of change? We don't have to accept as normal us developing high blood pressure and dying from high blood pressure. That we don't have to accept anymore. You know what I mean?
Guys, we're going to build off of each other because that's what we do. But one of the things that is really important for people to recognize, and everyone listening here, heart disease is the single most common cause of death in people in Detroit. Okay, and people in Detroit are much more likely, almost 2.5 times more likely to die of heart disease than anywhere else in the country. And when we look at data, it's called age adjustment, right? So what you want to do when you look at mortality or death data is age adjust, because you don't want to compare a community of 30-year-olds to 75-year-olds and say, wow, the death rate is so high here, it's worse. Well, no, people at 75 are closer to death than people at 30. But what happens when you age adjust mortality for heart disease in Detroit, the rate actually goes up because it's younger people dying. Dying earlier of heart disease. So not only is heart disease contracted more often, it occurs earlier, and it's all preventable, as Dr. Opara said, through better management of risk factors, especially high blood pressure.
You know, Pastor Chapman, we got the doctors who are really making some house calls by giving clarion calls today. Can we tackle some of these common myths here? Absolutely. And really kind of unmask these myths, if you will. There's one that says, I was diagnosed, or I was diagnosed with high blood pressure, but I've been maintaining lower readings, so I can stop taking my medication now. Is that really true? Or? So
I appreciate that adherence to the medication, all right? And so I just want to lift up that person's adherence to their medication, and that is why your blood pressure has been staying on the lower end, so keep it up. So my encouragement to that patient that says that is awesome, great work, and keep it up. So we will not be stopping our medication that is clearly working for us in that regard. Dr. Levy, what else would you tell that patient?
Yeah, absolutely. Don't change just because you're getting the results you want. Keep doing it and get better, right? Maybe if you add some of the other things to it, like weight loss, exercise, if you smoke, stopping smoking, other things, you can get off the meds if you don't want to be on the meds, but you got to do everything else that goes with the equation.
Dr. Opar, you brought up another thought, and it's going to take me in another direction, but I think that it's appropriate because we're talking to the Faith Community Research Network. And I know oftentimes I heard people, just say that I'm going to pray about it, or I'm not going to take medication, or, my grandmother said if I chew garlic or take garlic pills that this will, substitute for high blood pressure pills and things of that nature. And the Bible says that faith without works is dead.
There you go.
Dr. Connor opened up today in prayer with one of our favorite scriptures in 3 John 1 and 2. It says, "Beloved, I wish above all that you prosper and be in health, even as your soul prosper." What would you say to someone who is, for lack of a better way to say it, almost using faith as a substitute to do what they're supposed to do? How would you speak to that?
I think that is an amazing question. And as a practicing Christian myself, I love it. I call medicine an incredible gift. That is a channel through which God works. Because like we say, if God's will be done regardless. So when he's given us this gift, which has been with us since Imhotep, right? Since the ancient, times, the original Egyptians that began this practice that has now evolved into medicine today. If we know that to be true, it truly is a gift, So the way I answer folks that come with that, and I understand it, and I honor that mindset, I do, is to say, well, this is that gift. And God uses all kinds of tools and instruments to help us be better, to help us achieve that promise that you prayed about so beautifully, Dr. Connor, of life and life in abundance. So I say, eat your garlic. That's fine. Eat your, your chicken bone. Whatever that. Go ahead with that. Your vitamin D. That's all right. And your medicine. They can work together in complementarity. And we will work to make sure that none of that is counteracting each other or going to cause you harm. It is not an expression of lack of faith. In fact, it's an expression of gratitude that we are gifted with the medicine and the technology to make our lives better, So that's sort of one of the ways that I would approach that question. I do think it's a great question because it is so, it's so pervasive in our community.
Here's another myth that says people with high blood pressure have nervousness, sweating, difficulty sleeping, and their face becomes flush. I don't have any of those symptoms, so I'm good. Is that true?
I think that's the idea that a lot of people see high blood pressure as a symptom-based condition. If I don't have symptoms, I don't have a problem, and that's why this knowledge of the silent killer is so important, because the vast majority of people who have high blood pressure, even extremely high blood pressure, don't experience symptoms. We used to think of this nosebleeds as sort of being an indication that your blood pressure is too high. And I remember when I was training, someone once told me the nose is not a pop-off valve. It's not like you reach some magic number and you start to bleed out. That's not the way the body works. And a lot of people will have headaches as an indication of when their blood pressure is too high, but in the absence of headaches, it doesn't mean that you don't have high blood pressure. So I think the most important thing is to tell people to look at the numbers and believe the numbers more than the symptoms, which is why getting people blood pressure cuffs and getting people in the habit of regularly measuring their blood pressures is really important. This idea of knowing your numbers makes a difference, because when you could see it, then it connects. Because otherwise, I'm just telling you stuff, and why am I the right person versus what your body's saying?
Exactly.
So we're going to rapid fire some of these questions off.
Okay.
Dr. Levy, high blood pressure, someone say, runs in my family, so there's nothing I can do about it. Like, if that's their attitude, like high blood pressure is hereditary in a sense.
There's a strong genetic component to developing high blood pressure, but it doesn't mean you can't control high blood pressure. So we think a lot about resistant hypertension, meaning people who just can't get their blood pressure under control no matter what. That's only about 5 to 10% of all hypertensives. The vast majority of people, we can get their blood pressure under control through a combination of lifestyle, life circumstance modification, and medications. So short answer to your question, yes, you may have a family history of high blood pressure. So what? Doesn't mean you shouldn't do something about it.
Dr. Opar, let me toss this one to you. I don't use table salt, so I'm in control of my sodium intake and my blood pressure. This is what I use. I use kosher or sea salt when I cook instead of regular table salt. They are low sodium alternatives.
Well, a couple of things there. Great that there's an effort to try to lower the dietary intake of salt. But one of our mentors often likes to say that the food that has one of the most common food that has high levels of salt is bread. So we are surrounded by high salt foods everywhere. Foods that come from the frozen TV dinners, high sodium, canned goods, high sodium. So it's not just the added piece, it's the salt that already is in existence in many of the foods that we have. So learning to read those nutrition labels and being mindful of that is really key. So yes, good for those low salt alternatives, but you gotta be paying attention to already made foods that are actually intrinsically high salt, have high salt content for many reasons there.
That's good.
Awesome. Dr. Levy, we have a myth that says, I read that wine is good for the heart. Does that mean I can drink as much wine as I want?
This is actually a controversial topic. It keeps coming and going in terms of the health benefits of drinking wine, and red wine specifically, thought perhaps because of tannins or components of the skin and other aspects of the grape, that is, of wine. But I think where we're arriving now is, like anything in life, things in moderation are beneficial and things in excess are harmful. So a glass of wine a day, I think people still are in the camp that it's probably beneficial, perhaps not for your blood pressure unless it de-stresses you from the rest of your day. But the likelihood is that drinking wine is not going to be the solution for your hypertension. And certainly anything in excess is going to be bad. And we know that drinking alcohol in excess has direct impact on blood vessels and the heart itself. So I would challenge that myth and say, have your glass of wine, stop there, but don't think this is going to be your primary therapy for hypertension.
Here's the last one here, Dr. Opara. I have high blood pressure. My doctor checks it for me. This means I don't need to check it at home.
Very interesting. And so the question I would ask is, well, how often are you seeing your doctor to check it? There is some value to checking blood pressure at home, call them home blood pressure checks. And so that becomes important usually in the morning time, but really any time that you're able to. So we've seen that it is helpful as part of your own, again, we talked about agency and sort of being in charge of your own health management, right? To know your numbers and then work with your CMO, your chief medical officer, your doctor, your nurse practitioner, your healthcare professional there, to get it under control at appropriate goals. But I think it's just part of that taking ownership, right, of your self-care and of your own sort of care or health management piece. So my encouragement is no, get your blood pressure cuff, your blood pressure monitor, check it at home, know your numbers, and then bring those numbers with you when you see your doctor so that y'all are working together towards a shared goal for your ultimate health and wellness.
And the most accurate representation of blood pressure is really when you measure it within your daily life. When you come to the doctor's office, again, like I said in the ER, we're a little bit stressed out. Blood pressures tend to be slightly higher in the doctor's office, and measuring it at home gives you that real estimation. And not only is it good for you to know your numbers, it then gives us the more accurate depiction of, do we need to adjust medications?
Right.
If you measure your blood pressure at home and it's always under control, and every time you come see Dr. Opara in the clinic, it's elevated, right? And she adjusts medications based on that determination, that runs a potential risk of dropping you too low at home and causing problems. So there's a lot of value in measuring blood pressure at home.
At home.
That's good.
Awesome. We talked about health equity earlier, and we want to just kind of touch briefly on this because of the medical mistrust that are in communities of color. We talked about Henrietta Lacks in our earlier segment and some of those things. How important is it to you both that communities of color get the right information, the right medical information, but also to participate in clinical trials?
I can start with that. That the medical community and the healthcare community hasn't done right by Black folks, right? Indigenous folks, brown folks in this country, and certainly in this city for many, many years. I encourage everyone to read Dr. Harriet Washington's Medical Appetite. That is a book for everybody to read and know very clearly about. Another book, Medical Bondage, also great book. And there are many others. holler at me later. I'll give you those resources. So we talk about mistrust, but I also talk about institutional trustworthiness. So there is a lot of a role, an opportunity for institutions to show themselves trustworthy of Black and Brown participation, in this work, in clinical trials or other sort of health work, in order for us all to enjoy good, abundant, thriving, health and lives. So saying that to say that there's a first step where as institutions, we need to be part of justice work so that we can rectify and reconcile the harms, the historical and to some degree, a large degree, ongoing harms with our marginalized communities. And then in that conversation, we can be part of earning the trust of the community to ensure that there is optimal participation in these trials, that we need to be very clear that the benefits of that participation goes back to those communities and that they're enjoying that benefit as well. So there's a lot that can be said. That is a fantastic question. I look forward to other conversations where we have more time to unpack it, but that will be where I'll begin the response to that fantastic question. Dr. Levy.
And I'll say, going back to what I initially talked about, this concept of lifespan equality, if we don't look at things through an equity lens, we can't ever achieve equality in lifespan. And the fact that people die younger, 12 years, 15 years, less abundance of life in Detroit, that is the ultimate health inequity. And what do we need to do to fix that? It's not just going to be what we do as doctors in the four walls of our office. It's what do we do as legislators, as policymakers, as community members, right? What do we do more holistically to understand the why behind this and then affect change there by targeting those differences? And if it's as simple as there's a greater density of fast food restaurants in this community that already suffers disproportionately from strokes, the equity lens there is no more fast food in this community.
Wow. We can go on and on, but unfortunately we are out of time. Thank you again to my co-host today, Dr. Eddie Connor, to Dr. Opara, and to Dr. Levy. We appreciate your time and thank you so very much.
Thank you.
Thank you. Thank you, Rochelle.
Thank you so much for tuning in to our show on medical mythbusters regarding hypertension. We want to allow you to be involved with our network. You can contact us at www.faithcommunityresearchnetwork.org, and you can phone us at 313-577-5045. It's very important that we have a seat at the table to discuss the things that are happening in our community, medicine-wise and as well as faith. We want to send out a network survey. We'll have information on the screen about that as well. We need your feedback. We need to hear from you. We always talk about not having an opportunity and not having a voice. Here's your opportunity and your chance to have a voice at the table. Thank you for tuning in. On behalf of myself, my co-host, Dr. Eddie Connor, on behalf of our Faith Community Research Network directors, Dr. Haley Thompson, Attorney Bertram Marks, and myself, we appreciate you for tuning in. See you next time. Thank you.